You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
You're listening to the NASP Specialty Pharmacy Podcast, a collaboration between the National Association of Specialty Pharmacy and the Pharmacy Podcast Network. Each episode dives deep into trends, challenges, innovations, and patient-centric practices shaping the future of this dynamic and rapidly evolving industry. Whether you're a pharmacist or healthcare provider, patient advocate, or industry leader, you'll hear expert insights, real-world evidence, and thought-provoking discussion that highlights all that makes specialty pharmacy special.
In support of NASP's mission to empower specialty pharmacy stakeholders to advance the standard of patient care, NASP supports a free market healthcare system in which all specialty pharmacies compete on the same fair and level playing field, because that is in the best interest of the patients we collectively serve. NASP is committed to working with all stakeholders and policymakers to ensure that all patients have access to the life-saving medications they need and the high-touch patient care and support services they deserve from the pharmacy of their choosing.
Hello, my name is Sheila Arquette, and I am the President and CEO of the National Association of Specialty Pharmacy. I am delighted to welcome my special guests, David G. Mitchell and Ruth Chen, to this episode of the NASP podcast. David Mitchell, PharmD, MBA, CSP, and FCPhA, is the Assistant Chief Pharmacy Officer of Specialty Pharmacy and Home Delivery at UC Davis Health in Sacramento, California. A graduate of the University of the Pacific School of Pharmacy, he also earned his MBA from California State University, Sacramento. Dr. Mitchell was instrumental in establishing UC Davis Health Specialty Pharmacy in 2010 and has since played a key role in expanding specialty pharmacy services across the UC Davis enterprise. A progressive and forward-thinking leader, he has developed and created numerous specialized pharmacy roles and positions, strengthening clinical infrastructure, advancing patient-centered care, and enabling sustainable program growth. His professional interests include business development, accreditation, research, and data analytics. He is actively involved in education as a preceptor for pharmacy students and residents. Dr. Mitchell has served as president of the Sacramento Valley Pharmacists Association and as treasurer and current president-elect of the California Pharmacists Association. In addition, he has contributed to numerous committees within organizations such as CPhA, NASP, and ASHP. In recognition of his innovation and leadership, he received the California Pharmacist Association's Excellence in Innovation Award in 2018 and the National Association of Specialty Pharmacy Distinguished Service Award in 2024. Ruth Chen, PharmD, MHA, is currently the manager of the Specialty Pharmacy Hub at UC Davis Health in Sacramento. In this role, she oversees clinical services provided by specialty pharmacy program coordinators and manages centralized clinical specialty pharmacist hub services in close partnership with clinic-embedded pharmacists. Members of the Specialty Pharmacy Hub also serve as core contributors to the newly established Rare Disease Clinical Pharmacy team. More recently, Ruth has served as interim manager for clinic pharmacists across multiple specialty clinics. Prior to joining UC Davis Health, she worked as a clinical pharmacist supervisor at Ochsner Specialty Pharmacy and completed a PGY1, PGY2 Health System Pharmacy Administration and Leadership Residency with a Master of Health Administration at UW-Medicine in Seattle. David and Ruth, thanks so much for joining me today.
Thank you for having us, Sheila.
Thanks for having us, Sheila.
So, David, let's set the stage. UC Davis Health serves one of the largest geographic regions in California. Can you briefly describe the scale of your specialty pharmacy program and what differentiates it from other health system specialty pharmacies?
Thanks, Sheila. I'll try to be brief. That's a big question there. We do cover a large geographic area, which encompasses all of Northern California, from the Oregon border down to the Central Valley, the San Francisco Bay Area, and we also have many patients in Nevada. So this coverage area is over 30,000 square kilometers. And the specialty pharmacy serves nearly 10,000 patients. So you're right, quite a large area and a large amount of patients as well. We support our patients that are in complex therapies that come to our academic medical center. Our medical center differentiates itself through world-class education, research, and patient care. At the health system, we have the UC Davis Comprehensive Cancer Center, numerous centers of excellence, and many national key opinion leaders. We also have a top school of medicine, school of nursing, and we are a site for UCF School of Pharmacy rotations for students. We also have an award-winning residency program with a large number of residents. In fact, this year, 46 residents are practicing at UC Davis Health in our pharmacy residency program.
Wow.
Yeah, so I've been told that is the largest in the country. I don't have that verified, but it is quite a large amount of residents and learning going on. And so they're quite integrated within our specialty pharmacy and all aspects of patient care in our pharmacies and in our clinics and in inpatient. Every aspect of the health system, we have pharmacist residents involved. That being said, a lot going on, but I do think the number one thing that differentiates us are our people. Our pharmacists through residencies, other experience are extremely well trained. They're also, many of them are board certified in the area, the specialty that they practice in, such as oncology. Many of them also have the CSP certification. And then have a lot of experience practicing in their specialty area. We also get the cream of the crop of our technicians. We have a lot of technicians that have many years of experience in retail pharmacy, specialty pharmacy, and managed care. And many of them also have board certification. A lot of training and a lot of certification, but the number one thing that I believe that differentiates us is that all these folks are very patient-centered and very patient-focused. And so I think that really is the top differentiator. We also have quite a focus on kind of our digital footprint and technology and research. We like others around the country, have full integration with the EMR, but we also are integrated within our dispensing system so that providers and patients can see all their dispenses right in the medical record. Our case management system, Compass Rose, is also embedded with Epic as well. And we also push the envelope with, being early adopters of things like Hello World for texting or artificial intelligence used to improve our prior authorization process. Our staff are embedded in the clinics, and we'll talk more about that. But they're part of the patient care team, and they have access to instantly have lab access, node access, and so really all that comes together to help optimize safety and efficacy. And that really translates to getting patients the correct, safe medication in a very quick start time. A lot of proactive work around safety and monitoring. And that translates also to better adherence and better therapy outcomes.
So let's talk a little bit more about how being embedded within the health system changes, right, or optimizes what specialty pharmacy can deliver compared to standalone models, right, where people or organizations aren't embedded.
Yeah, I think that is a big piece of what differentiates us, and our clinical pharmacists that are very well trained within their specialty area are embedded within the clinic. So they are part of the care team. They are a part of the process of selecting therapy early on. When the patient comes to clinic appointments, they often see the pharmacist separately or as a part of a shared visit with the physician. They're often consulted on therapy selections or a part of their collaborative practice agreement are prescribing these therapies. A big piece is, again, the people. So our folks are meeting face to face with patients. So we're getting to know the patient themselves, involving them in the care process and decisions, getting that face to face time, building that trust. So I think that, translates to a good working relationship with the patient and the physician down the road that then help translate to safer and better therapy outcomes. Also, all of this work goes to really streamlining the process. Since early on, we can be doing things like benefit investigations, looking at formularies to help understand what might be the most cost-effective therapy for the patient, along with what is best for their condition and their lifestyle. All of this pre-planning and face-to-face time really helps decrease the patient bouncing around or getting lost between different silos, and really streamlining the process. So we're able to address things earlier on, make earlier interventions to help decrease things like side effects. We're able to watch therapy and titrate therapy, I think, more closely, and then just overall provide a smoother patient experience for the patient through the whole process.
So what are the biggest payer or policy challenges facing health system specialty pharmacies today, and how is UC Davis addressing them?
Well, we do face significant challenges around the ability to dispense specialty medications for patients due to what we call payer lockouts, which a lot of that is driven by vertical integration of large specialty pharmacies and PBMs. So we do help patients navigate this we actually do a lot of the process for the patient and for these specialties pharmacies, such as the prior authorization. We believe that having that aspect equally done for all of our patients helps them through the therapy process. Mm-hmm. We often had patients coming back to us that we did not do these services for. So, that's one aspect that we help at least patients navigate some of these issues. We also provide clinical services to all of our patients as well. So some of that, the education piece, the monitoring, even if we're not dispensing the medication. So that helps the patient and helps streamline therapy as well. To help, it is our goal to be able to dispense for all of our patients, because we find, the clinical portion goes very far to help with outcomes, but there's only so much we can do. Mm-hmm. We can't guarantee the streamlined, integrated experience that we give to the patients. We can do clinical management and dispensing for if we can't also dispense the medication. So we have, opened up discussions with a number of payers to open up those contracts to be able to dispense for all of our health system patients. We've also, as far as regulatory, worked with our legislature in California to help ensure open access to patients and then fairness within the PBM space through a recent law that went into effect, SB 41. So, really, trying to smooth some of the road bumps of payer access through our clinical activities, is a focus. Interfacing with payers to see how we can, find win-win situations and open up some of those contracts, and then being active legislatively and getting active with advocacy. It really has been how we've tried to address some of those issues and regulatory issues that we face.
Do you only fill prescriptions for patients who are seen by your health system physicians?
For the most part, yes.
Okay.
But we do provide prescriptions. We're open to the public,
Okay.
so we have an ability to fill a prescription and bill a prescription for a patient who walks in off the street. That is a possibility. Some cash patient, but overall, predominantly nearly all of our patients are health system patients.
Okay.
Yeah,
Well, that's incredible that you provide all of those services, right? Whether or not you can dispense the drug, because that's where all of the work effort and the cost is.
It is, and we are working through what is provide the patient the maximum benefit clinically to help with those therapy outcomes, and we concentrate on those. But we also find we can only do so much. And
Right.
so we do have to let other specialty pharmacies do a piece of the work. And then obviously we can't dispense the medication. And so we, unfortunately, with all the work we do end up, the other thing we end up doing is a lot of, I guess, helping and triaging issues and end up playing an intermediary with external specialty pharmacies because of the issues our patients face. And unfortunately, a lot of times if we were able just to fill the medication, those would not be problems in the first place. But those are some of the daily issues, especially our pharmacy technicians and pharmacists have to deal with. But we try to do the best we can to help all of our patients.
Yeah, and I'm sure that your physicians and your providers appreciate that, right? Because you're still contributing to the successful outcome of this patient on which they are graded, right? Or they're monitored.
Yeah, and from a physician standpoint, it's really for them to differentiate between a patient that fills at our specialty pharmacy and one that doesn't. And they're really concerned with all their patients. And going back to that relationship of the clinical pharmacist in the clinic, they're also there as part of the team for the clinic. And so they want the best for all their patients. But going back to the providers and physicians, they really highly love our services. I always remember one of our first clinics where we had a very, very nice physician, but just honestly say, I have no idea what a pharmacist is going to do in my clinic. Or they're going to be dispensing medication. And then within a year, that physician was like, I don't know what I would do without my clinical pharmacist, because they've become such an integral part of managing their patients, especially in all the biologics that are out there. And we are finding comments on our provider survey that we use through NASP annually of just amazing feedback from these physicians. It decreases physician burnout. They're able to see more patients. They're able to provide therapy, safe therapy that's more effective because they have the pharmacist a part of the care team. And just the feedback of our overall services are just amazing from these providers. So they really do appreciate our services. And then, we do the quarterly NASP patient survey and, get amazing feedback from our patients. So we really feel that, from the feedback we get from patients, the feedback we get from providers really speaks to this integrated model and just the benefits that our patients providers receive from the model and the care that we provide.
Yeah, I have a son who is a surgeon, and we were discussing some of this, and and this kind of hit me because he said, we're held accountable for these outcomes, but we can't pick anybody that we want to work with, right? We're told what pharmacy, what imaging, what lab, even sometimes, no, not that drug, this drug.
Yeah.
And I thought, wow, that's pretty interesting. And he tells me the same thing because he's at, a health system or hospital health system. And that's what he said, it would be lost without my pharmacist. He's like, they're amazing.
Yeah, yeah. I mean, we in a lot of our clinical areas don't work with surgeons, but one area we do that comes to mind when you mentioned your son is transplant. So, oftentimes they do get a chance to work with us, and we've shown that we are able to keep our patients more adherent and have better outcomes that utilize our pharmacies. And the surgeons and the clinic physicians, really appreciate the services that we provide. And that was one of our earlier programs. Actually, was our first program that started in 2010, and just has become just a real key component, the success of our transplant program here at UC Davis Health is having that integrated pharmacy within that program.
That's awesome. So as we look to the future, what innovations or strategic initiatives are you most excited about that are going to impact the future of specialty pharmacy at UC Davis Health?
Yeah, so I'm really excited about the future at UC Davis Health specialty pharmacy. I'm really excited for, all the amazing therapies that are coming to market. We've really not shifted, but we've opened up an approach to caring for disease states, rare diseases where patients, there's a smaller patient population. So we've established our rare disease center within our specialty hub, which Ruth will tell you more about. We are seeking rare disease URAC Center of Excellence certification here coming up next week. So we're really excited about that and really trying to meet the needs of rare disease patients. And I really do think we've talked a lot about that integrated care model and what makes UC Davis special. And I really think all those things come together to, really provide an excellent situation to provide the best care for these patients with rare diseases. We're looking at, through technology and data analytics, really improve our research that we do. I'm really excited about that. We have our director of specialty value and trade relations, Tiffany Fung, that's heading an effort to really improve our relationship with pharma and really be a partner to research these agents and in practice and really help and improve the outcomes that our patients are receiving with these medications. I'm really excited about those partnerships and what that research will highlight and really help to drive to improve care. We really focus on technology in improving digital communication with our patients. So we've invested a lot in our app, our patient portal through My UC Davis Health, or also known as MyChart through Epic. And so providing a lot of self-help tools and education that patients can receive at the time that they want to receive it or, interact through that portal. We've also, invested in texting so that patients can receive text and we can a lot of patients, like that ability to communicate in that fashion. We're also looking at how we can improve the quality of our operations and efficiency as the specialty pharmacy gets larger and serves more patients. So we're looking at how we can employ technology such as artificial intelligence with prior authorization and other processes to be able to, further improve things like speed to therapy. We're already amazing, but we're always trying to push how we can do better. And so we're hoping technologies like artificial intelligence, and where the early signs that we're seeing of some of the implementations of that technology, we have seen reductions in turnaround time and improvements. So we're really hopeful that will continue to help us improve the patient journey and through the prescription process. So really looking forward to further leveraging technology to improve the process and patient care.
Well, now, Ruth, let's chat with you and let's talk rare disease and why strategy matters. So why is it important for a health system specialty pharmacy to have a focused strategy for rare and complex diseases?
Yeah, Sheila, I think this is a great question because as Dave kind of highlighted, our specialty pharmacy program here at UC Davis services patients, that are geographically diverse and expansive, but also with the way our program has grown in established clinical areas, we are starting to see those patients who have rare and complex diseases that are within those kind of your bread and butter specialty pharmacy spaces. Rheumatology always has some of those classifications of rare diseases. Our cardiology clinic definitely does as well. And so while those clinic pharmacists are able to support these patients under our specialty pharmacy model, there have been instances where it's been identified that there are patients who, because of their rare diagnosis or like the limited distribution of a drug, we've needed to explore having a team that can support these patients because they've come to UC Davis for their care, because we have a provider who is a leading expert for that disease state. And since our specialty pharmacy program has grown and we've had the footprint that we've had in our specialty clinics, it's also meant that we have these smaller clinics that maybe we don't have an embedded pharmacist in, but that is the clinic that a patient is seen at who has a rare disease, who in the last few years finally has a drug treatment option available to them because we've gotten to that point. And ultimately, that patient, in order to get a therapy that treats their condition and manages their condition so that, they can go about their life and kind of feel like there is a solution and a medication that is beneficial to them, they do need our pharmacy team's support. But the reality is, a lot of these disease states, we have very few patients within the system who have the diagnosis and meet criteria to be on these therapies. And as a result, the way that our specialty pharmacy program is set up, we can't justify allocating one pharmacist to that clinic to serve 5 patients. But if we centralize that model and we look at the opportunity ahead of us as we get access to these therapies or establish relationships with these providers in clinic, we'll be able to support those patients and provide that quality patient care that we pride ourselves in.
Yeah, I was a pharmacy director for a health plan for many years. And so for some of these, rare and orphan disease patients, we never knew that they were part of the plan until a treatment became available, right? Because there was nothing anybody did for them. And so they didn't, rise to the level that would get somebody's attention. So that's how I remember when the drug for Duchenne muscular dystrophy became available, we were scrambling, trying to figure out, okay, how many of these patients do we have? Right? Because we didn't even know. There was nothing to treat them, to your point.
Right. And interestingly enough, that is actually one of our clinics here that, the team supports those patients. And while we don't have access to the therapies, we're seeing the success story of those patients on the therapy. And so we continue to support them on that journey. And, our hope is if we demonstrate our value, we can kind of break down some of those barriers that will make it easier for those patients, whether they will ever be able to use our pharmacy or not, but at least they have access to the therapy, and they have a pharmacy team member who could support them. But definitely our rare disease team has been centered around the medications that we do have access to and the patient populations. However, we are hoping that one day that model expands to continue to support patients who do have some of those rare diseases that right now our pharmacy will not be able to dispense for, but we have a service that can at least ensure that they don't have gaps in care.
So before implementing the rare disease hub model, what were the biggest challenges UC Davis faced in managing rare disease patients? And how did those challenges shape the development of this hub model and its core functions for both patients and the providers?
Yeah, so definitely a two-part question here. So I think the first part, some of the biggest challenges I kind of addressed earlier is, where are these patients being seen? Which providers are seeing them? What is their therapy selection strategy? And do they even know that they could ask pharmacy to help them out? And I think anecdotally, in my time here at UC Davis, one thing I have learned is that when providers for complex therapies don't have support and they and their clinic staff are kind of on their own navigating the first patient that they're trying to get on a therapy, the pharmacy speak of navigating insurance and identifying what pharmacy needs to fill a therapy is kind of something that pharmacy is the expert on. And so that was something that we really took to mind when we were exploring and justifying why we wanted to bring around a centralized hub model that would be able to support these rare disease patients. And so in terms of challenges in developing this hub model, Dave talked about, we have really good clinic-based footprint with our pharmacists. So developing a centralized hub model meant that we had to identify what patient population this pharmacy and pharmacist team was going to, number one, focus on. And then number two, without really talking about division of work, how do they work together if a patient is seen in a clinic that does have a clinic-based pharmacist, but really that clinic-based pharmacist is not going to be the best individual to support the rare disease patient. And so, that takes a lot of collaboration and teamwork, dialogue between different groups, and just kind of realizing who is ultimately going to make the best sense to get the work done. I've been at a couple different health systems, and I went to pharmacy school in the Midwest. So I feel like I've seen pharmacy practice and healthcare practice across the country. And let me tell you, we don't practice pharmacy, and providers don't have the same healthcare practices everywhere. It's not the same. And kind of learning and understanding and adapting to how care is delivered, what the mission and values are here at UC Davis, and how our pharmacy team prides itself in a very progressive practice under our CPAs, while also recognizing that there's therapies and disease states that don't live under those CPAs, and therefore we do need the providers to really work with us to ensure correct documentation and that labs are ordered and that they send a medication order to the correct pharmacy so the patient can actually fill the medication. And So those are just some of the challenges and conversations that kind of came about when it comes to developing this hub team. And then in terms of like core functions for patients, the pharmacy team and providers, I think it was easy for us. And I say that loosely. It wasn't truly easy, but we had a really good framework to work off of coming off our specialty pharmacy model, that it was really about what needed to be adjusted to meet the needs of, the rare disease patient population. Dave mentioned we're going up for URAC rare disease COE, and there's a couple extra things that we need to do. So instead of reinventing the wheel, it was looking kind of what is extra on top of the way we already provide care as a team to ensure that those needs are being met. And that doesn't happen overnight. That's a reflection of how our specialty pharmacy team has been built over the last decade and how it's grown and how we've optimized and used those technologies, tools, the workflows that we have to have allowed our program to grow to the point that it is at, that we can really look at this patient population and say, we know that we can do this, and that's why we took the time to develop it.
So once a patient qualifies for therapy, and this is another two-part question, what does the journey look like from education through initiation and monitoring? And what payer, operational, or manufacturer-related barriers are most common in rare disease programs?
Yeah, so when a patient qualifies for therapy, and I'll go ahead and use our hypertrophic cardiomyopathy patient population here. When a provider has determined that the patient is a candidate for therapy and has written that prescription, it is transmitted through our electronic medical record, which is Epic, and it's captured in our MSOT queue. And a cardiology technician grabs that order and essentially starts a benefits investigation and works on a prior authorization. My experience has been that the advanced cardiac therapy provider group really has their documentation down, is really good at making sure that a patient is not going to start therapy if they don't meet all the criteria. But in the event that there's ever information for a prior authorization that a technician needs that they can't find in the chart, they work with one of the clinical pharmacists to verify or seek that information and then ensure that it's documented in the chart, so that we can kind of navigate the insurance coverage process as smoothly as possible. Our goal is to always get coverage for a medication for a patient, and so that includes navigating an appeals process if the request is denied, working with the provider if needed, if additional information is needed based on plan-specific criteria. And then ultimately, once that PA is approved, we work through the cost of the therapy for the patient. And we, inform the patient what the cost of therapy is. Most of these patients understand that this is a therapy that you're taking long-term and not like an antibiotic where you take it for, a few weeks and you're done. And so while some patients might hear a copay and be like, oh, that sounds okay. We do have to remind them, like, this could be a copay you're paying every month, or if you ever change your insurance, it could look different. And so we navigate that conversation based on what needs the patient has to ensure that if they are starting therapy, they will be able to stay on therapy. In terms of, payer and operational considerations, the drug that we have access to for this patient population has a REMS program. So that means that our pharmacy had to get REMS certified. All the staff needed to be trained so that they could have access to the portal to ensure that we were logging and screening patients at every fill appropriately according to the criteria. And then there are some patients who can't fill at our pharmacy and they have to fill externally. And so going back to the fact that we use MSOT, the technician is able to then release the order to the filling pharmacy, whether that's ours or an external pharmacy. And then from there, that's kind of where things deviate. If a patient has to fill externally, this clinical provider group has a great nursing team in their clinic, and they kind of coordinate and work with patients who have to fill externally. But for patients who fill internally, at that point, our pharmacist will do a thorough initial medication counseling and start to therapy education for the patient. And that's really in addition to that upfront conversation that the provider has already had with the patient before determining that they want to put the patient on therapy. Just with all the screening and monitoring requirements, I don't think we've ever come across a patient who was shocked when the pharmacist reminded them that they, will be having periodic echoes and there's going to be possible dose changes and titrations. Most of the patients had acknowledged that this was information that had already been shared to them by the provider or clinic staff. And then at that point, it's all about working with the patient to figure out the best form of communication with them, when we're going to dispense the medication, and how to ultimately ship the medication to the patient. And, we do have patients who live quite far away from Sacramento here in the Northern California region. And I do know we have had patients with this disease state who've lived along the California and Nevada border as well. So when you really look at the distance that these patients have committed to not only seeing one of our providers here in Sacramento, but then the monitoring requirements that they need to meet, whether that's coming back to a UC Davis facility or, an external location, and then working with our pharmacy team telephonically. There's a huge commitment on the patient side as well to be on these therapies. And, our team has always prided ourselves in really communicating and working with the patient to work through those barriers. I think that kind of touches on most of the payer operational, and then trying to think if there's really anything else that comes to mind.
That's enough. No. So as we're looking ahead, how do you see the HCM model that you and the UC Davis Health team developed being replicated across other rare or genetic conditions within UC Davis Health?
Yeah. So Sheila, like I said, I know that we have a lot of rare and genetic condition patients that are seen in our established specialty pharmacy service lines with clinic-based pharmacists, and those patients live within those established programs. I don't think it's not a priority for us to pull those patients out into the rare disease team, because ultimately that patient can see that pharmacist in the clinic and it is able to be supported there. However, one day I think there could be a therapy out there that would necessitate us pulling that patient population out just because of some of the operational complexities, or it takes more time if that patient continues to live in a larger program, and the resource needed to kind of move through some of these barriers. I alluded to our partnership and work with some of our smaller clinics where patients do have rare and genetic conditions here at UC Davis. And I have been having conversations, and we're continuing to actively monitor our opportunity to have access to those therapies. And then, that would then potentially be the next opportunity for us. So some things I think about, are our Duchenne muscular dystrophy patients, our ALS patients, like our spinal muscular dystrophy patients. And then if we ever come across anything else, or if a new therapy comes along that helps us identify a patient population that is seen here at UC Davis and receives care from a provider here.
Well, I want to thank you both, David and Ruth, for chatting with me and sharing this valuable information.
Thanks, Sheila.
Thanks, Sheila, for the opportunity. Really appreciate it.
Of course. And as a reminder, NASP corporate members are invited to be my guest on one complimentary podcast per year. For more information about this or other NASP membership benefits and events, please feel free to reach out to membership@naspnet.org or visit our website at www.naspnet.org. Until next time, have a great day.